Greetings from Bilmed Group of Institutions. Today we are going to have a small interactive session, and this will be a doubt clearing session. This session is for those who are registered with Bilmed for different server-based courses, and they are posting their queries, their questions, their doubts at regular intervals, and we are compiling the doubts and are taking these types of sessions. And with me is the list of the questions, as you can see over here. I will be taking questions one by one. So the first question from Dr. Nivedika. Dr. Nivedika is posting a question that I will read as it is. What I mean, this is the copy pasted question. The language is original. The question reads like this. I can scan the liver and gallbladder through intercostal spaces, but through subcostal plane, I cannot get a good view. The point here is that some doctors are getting difficulty in intercostal spaces. Now, why it is so? Let me share the screen first for better understanding. Now here, when you are putting your probe through intercostal space, your probe is first of all big enough to fit in the small intercostal spaces. So you have to fit your probe in between the ribs to get a better view. For that, the footprint of the probe is big. What I will suggest you to go for a probe which is having a small footprint, and that can be a linear probe, that can be a probe which is used for echocardiography. The point here is that you have to fit your probe in between the ribs, then only you will get a good wave through intercostal space. Now, somebody is more comfortable, more comfortable, is getting a good wave through a subcostal plane. Now, why they are getting? Because sometimes the patient is not very obese, and when you are asking the patient to take a deep breath, what is happening that the diaphragm is pushing down with the deep breath, and thereby you are getting a better visual plane of the liver. So the moral of the story is that you have to fit your probe in between the ribs to get the better intercostal scan plane. And you have to move the patient towards the left side to get a best view of the subcostal plane. That was first question. Second question from Dr. Amita. It reads like, sir, how to see chronic cervicitis? Kindly clear it. Now, the chronic cervicitis, when I say chronic cervicitis, the ultrasound findings will be, there will be 4 to 5 points what you have to keep in your mind when you are seeing for a, chronic cervicitis patient. When you are, suspecting a chronic cervicitis patient. Now, first of all, endocervical canal, first of all, the endocervical canal will be fuzzy. The heterogeneous endocervical canal will be there. That is point number one. There can be, the normal bright line of the endocervical canal may appear blur, thick, or uneven. And that is the heterogeneous endocervical canal. That is point number one. Point number two, there will be some hyperechoic inclusions. When I say hyperechoic inclusions, I mean small bright dots will be seen in endocervical canal. That is two. Third, or fourth, probably third, is the cervical wall itself. Cervical wall will be thickened. The overall thickness of the cervix will be increased. That is next point. That is probably the third one. And the fourth will be, there will be some cystic structures. small cystic areas, these Nabothian cysts, these are actually the Nabothian cysts may be present in case of chronic cervicitis. And these are usually the incidental findings which usually appear in these patients. And the last is your color Doppler. When you are putting a color Doppler onto the cervix, and if it shows the increased vascularity, that is also going in favor of chronic cervicitis. Now, one finding will not give you a diagnosis. You have to keep your 5 points, these 5 points in your mind. And if patient is fitting clinically also, then that is a chronic cervicitis case. Next question from Dr. Bhagishri is regarding the OB scan. The question, that is a lengthy question. It is regarding the knuckle translucency. It is regarding the knuckle translucency. The first part of the question, there are multiple questions from Dr. Bhagishri. Can NT be measured with fetus facing down and spine up? Now, first question from Dr. Bhagishri is that if fetus is upside down, I mean that if this face is downside, can I get a good NT? In fact, that only is the best plane for knuckle translucency. I'm not saying for NBNT scan, not for level 1, but to get the knuckle translucency, that is the best position of the fetus when your fetus is having spine up. With spine up, what you will hit? You will hit this knuckle translucency first. So the knuckle translucency in face down patients in these fetuses will be having more clarity than face up, because the beam is hitting through the complete fetus, then only it is coming to the knuckle translucency NT. But in face down, it will be hitting first. So that is the best position the fetus is having if you are seeing for NT. But the point is, NB will not be clear with that position. If the face is down, then this nose, this nasal bone will not get hit by the beam first, but beam lastly. So NB will be blurred, will not be very clear. So it is completely depending on the fetal position. So if you are more concerned about the knuckle translucency, then the best position of the fetus is face down. And if you are more concerned, I mean, if you want to see more clarity of nasal bone, then it is the face up position. Next question from same Dr. Bhagishri is that whether uterine artery Doppler measurement is mandatory in first trimester. Now see, the point here is that in first trimester ultrasound, why we are scanning the uterine artery? Because we want to get a rough idea. Those who have already completed the color Doppler will better understand me. When you are scanning the uterine artery in first trimester, what you are actually seeing for? You are seeing for a trophoblastic invasion, not seeing trophoblastic invasion directly, but you are getting a rough idea of trophoblastic invasion. If there is an impaired trophoblastic invasion, that will be reflected by the uterine artery. And if there is a weak trophoblastic invasion, that patient is having a high risk of PIH. So for PI screening, you have to scan the uterine artery in first trimester. And if first trimester is showing you some abnormalcy in uterine artery, it means that this patient is having a high risk for PIH. And if patient is already having the history of PIH, then it is mandatory to scan the uterine artery in first trimester. Then the third part of the question is, or the third question is, what should be the scale in the Doppler setting? When I say scale, settings of the overall color Doppler, you have to go back to the class. That is the color Doppler setting. It is the complete class. Please go to the server and revise it again. Because right now we are taking the question and answer sessions only. We are taking the doubt clearance session. It is the complete, class for the color Doppler settings. I will highlight some important points. The first point is that when you are putting a color box, don't expect the image to be clear when you are putting the color box. In fact, the frame rate will drop. That is number one. Number second, if you are putting a big color box, the frame rate will dramatically drop. So what you have to do, you have to adjust the box and keep it as small as possible. I am using the word as small as possible because it is completely depending on the area of interest, whatever you are scanning. So keep your scan box, this color box, as small as possible. Number third is that your color box should not be horizontal. It should not be more horizontal. It should be more vertical, because these points will tell on the complete frame rate, and the complete frame rate is defining the resolution. So these were some important Doppler settings while you are putting the Doppler anywhere while scanning. So again, requesting everybody whosoever is concerned about the Doppler settings, go back to the Doppler class, and the complete class is there on the server of Doppler settings. Now, the fourth is that a report regarding the report of the first trimester. What you have to see in the first trimester, whatever you are seeing now, see, there is no fixed format for any trimester. Whatever you are seeing over there, whatever you are supposed to see, you have to report that I have seen this, I have seen this, and I have not seen that. Now, in first trimester, what you have to see, you have to see for the nasal bone. So mention the nasal bone. You have to see for the knuckle translucency. You have to mention the knuckle translucency. You have to see for the crown rump length. So you have to mention the crown rump length. How much is the crown rump length? And the total gestational age calculated as per the CRL. On the top, you have to mention whether you are seeing the full grown of fetus. When I say grown of fetus, I mean that whether the calvarium is there, the fetal head part is not missing. You have to mention that, and you have to measure the biparietal diameter also, because sometimes maybe that the BPD is ahead or lagging. That will give me an idea in second or third trimester whether I have to see more carefully there or here. So whatever you are seeing, what you are supposed to see, you have to mention that also. You have to mention the fluid. You have to mention the cord insertion. You have to see whether there is no defect in the at the level of the cord insertion. But you have to be very careful over there, because many times you are seeing this defect like thing in late first trimester, that is the pseudo gastrocesis. So the moral is that whatever you are supposed to see, that is your format. You have to mention that. Next question is that at 14 to 16 weeks, BPD and femur lengths are enough. Now, see, at 14 weeks, I will say that you have to take the CRL plus BPD, head circumference, of course, and femur length. And usually we are not taking the abdominal circumferences at 14, 16 weeks. Yes, you are right. You have to see for, BPD, head circumference, femur length, along with the CRL in first trimester. Next question is, let me share the screen for better understanding. Now, this is the rough format. I will say the rough format of the ultrasound report. You have to mention the number, you have to mention the position, you have to mention how much is the heart rate, you have to mention the amniotic fluid index, and you have to mention the MVP also. You have to mention the placenta, whether it is anterior, posterior, whether it is normal, whether there are any additional placenta. Whatever you have to see in placenta, you have to mention it over here, whether there is a sucentrate lobe, whether there is any additional lobe, whether the cord insertion is normal onto the placenta. Then you have to take a brief anatomical survey of the heart also in second trimester, whether you are seeing a four-chambered view, whether you are seeing a normal cord insertion, whether the bladder and the kidneys and stomach bubble. Stomach bubble is very important. Are they well placed? This stomach bubble is not relocated somewhere. I am talking of some defects over there. You have to mention about the spine also, whether there is any defect or not. And for that spine, you have to take the complete spine view in longitudinal as well as in transverse. So at the end of the day, the machine will give you an estimated gestational age and will give you, the EDD. But see if your EDD is corresponding with the LMP. And if not, go back to the first trimester scan and see what was the EDD in first trimester, because the EDD calculated as per CRL remains superior throughout pregnancy. This is also already discussed with you. Then measurements, what you have to see for the BPD, you have to see for the head circumference, abdominal circumference, femur length, of course, and the femur length to BPD ratio. The machine will give you all these things, but you have to give the BPD and femur length, and the ratio will be calculated by the machine thereof. What you are doing, you are not missing any skeleton abnormalities by these ratios. You have to see for the cephalic index, and you have to see for the SCEC ratio. What for the SCEC ratio is to see whether I am having any discordancy in this ratio. That will give me a rough idea whether I am having any asymmetrical IUGR and all these things. So this is the rough sketch of a format what you should be having. Now, from the gynae scan, next question is from the gynae scan. Now, see, the question reads like, for follicle, listen carefully question. For the follicle study endometrium, for assessment of blood flow, when we take power Doppler, what should be the settings? Again, settings part. Settings are completely depending on what you are seeing. If you are seeing a small area, now for example, what I mean, if you are concerned with a small area, then why to put a big color box? Now I cannot say that you have to put a small color box only, because if you are concerned with the more area, then your color box should be big enough. So it depends on the area of interest, whether it is small or big. Depending is the color of the size, that box. Now the question is reading like, let me go to the slide. Now, for example, over here, now see, for example, over here, the color box cannot be small, because, now see, because I have to see the vascularity in whole of the endometrium. Now I cannot say, nobody can say that you should have this much of color box and you should not have this much of color box. If you are concerned about the whole endometrium, then your color box has to be accordingly this much big. And here I told you that the color box should not be more horizontal, but I have no way other than to put a horizontal color box over here. So that is the point. You have to see what you are seeing will decide you the color Doppler settings. Now over here, if I increase the gain, now see, if I increase the gain, color gain, the same gain knob will now function as a color knob. This is physics and ultrasound machine settings. Go over there. It is in detail over there. So the point here is that how much should be the color gain? The color gain should be at the level, listen carefully, at the level where I am not getting these vessels mixed, overlap to each other. If I see more colored area over here, it means that I have overgained the image. And if I see a less color, for example, over here and over here only, it is not straightforward that it is an avascular area. The chances are that you are having an undergained gain. So increase the gain, and if the increased gain is not showing you more color, then only it is avascular. So the point is that you have to be very clear with the color Doppler settings. Now, the next question, describe how to describe, especially difficult cases. This is the copy pasted language of the question. I'm making it simple for others to understand. The doctor is getting difficulty in reporting adenomyosis, tubo-ovarian masses, and hydrosalpinx. How to describe it? So the question is like, if I am having a hydrosalpinx, how to report it? How to report it? Don't straightforward write a hydrosalpinx in red line, because that can be catch. If it is not hydrosalpinx, then you will be caught that you have written it in red. So better to describe the ultrasound findings that, for example, in case of hydrosalpinx, that I am seeing, you not write it, I am seeing there are anechoic cystic lesions in right side or both sides or left side with incomplete septations. And on color investigation, these septations are not showing an increased vascularity. The findings are likely suggestive of hydrosalpinx. So your wording should be like this. And for this tubo-ovarian masses, there is a heterogeneous mass measuring this and this much in right or left side of the uterus. The ovaries are seen or not seen separately. That I don't know whether you are seeing in that given case or not. And on putting a color, this much is the vascularity. It is increased or decreased, that thing. And the uterus is appearing separately and is measuring this and this much, and the findings can be suggestive of a tubo-ovarian mass. That is it. Now, the last question is regarding the scale of the uterine artery. When I say scale, what is meant by the scale? When you see a flow, when you see any flow, let me write it, draw it over here. Now see, when you see a flow on the type of, let me change the color. When you see any type of flow, this is systole, this is diastole, then there is again systole, and this is diastole. The uterine artery looks like this. Now the question here is that how much should be the scale? Velocity, I mean. How much should be the velocity? Velocity, now see, if for example, this peak is corresponding to 80. And if I put the scale not at 80, but at 40 only, try to understand. But at 40 only, can I say this peak? Yes or no? I will not see this peak. On ultrasound, I will not see this peak because I have put it at 40 only. So I will see everything up to 40 only. It means that I will be seeing up to this. I will not see this peak because this peak systolic velocity is at 80. Now, how much is the peak systolic velocity on an average in a uterine artery is in between 80 to 90. Sometimes it is touching 100, sometimes very rarely. So if I keep this peak systolic velocity at 100, 110, then these peaks will not be missed on ultrasound. So the reply to the question is that keep your peak systolic, velocity at about 100, because this peak systolic velocity is about 80 on an average in a uterine. That was the last question. I hope that you have got answers to your questions. In case you will be having your questions in future, but I'm requesting you to complete the topic or at least to touch the topic before posting any question, because many times you will be having questions from uterine artery, umbilical artery, ductus venosus, and you have not even started the color Doppler. So better not to post any question from the topic what you have not even touched, and best is to complete the topic and you can post your questions to our helpline number, and we are taking these types of doubt clearance sessions at regular intervals. Stay connected. You'll be getting notification from our helpline number regarding the next interactive doubt clearance session. Hope you are enjoying our sessions. Thank you very much. God bless all of you.